Hello, everybody. Welcome to Medicine and Science on the Pod TV network. I'm Nick Helvey. I'll be your host for today's program. And today we have a very interesting subject we're going to discuss because it is the number one killer in the United States and perhaps the number one killer in the world. In other words, when people say, "What are you going to die of?" and you're afraid of like dying by a shark attacking you, that's probably not going to happen. Or you're afraid that you're going to be eaten by some animal. That's not going to happen. But here's what's going to happen. The number one killer that we've seen is heart disease. And so we're going to be discussing heart disease and also vaccines and the relationship with heart disease. But I'm not a medical doctor. As you can see, I'm an attorney. And I know there's an attorney who's pretending to be a medical doctor in Washington, D.C., but I'm not one of them. So instead, it's better to have a doctor discuss that. And with that, we do have a medical doctor, Dr. Michael Patmos, who many of you are familiar with, who is board certified in internal medicine and has extra qualifications in infectious diseases, who will discuss this particular area with us. So which means you don't want to listen to lawyers. We talk a lot, but you don't want to listen to them, especially when it comes to medical advice. So RFK, step down, please. And instead bring in Dr. Michael Patmos, people that are familiar with him on the network. And so you're the person I want to listen to when it comes to medical issues, Dr. Patmos. And so heart disease is a big one. Some people have that say there's a relationship between the vaccines and heart disease. So listen to you and see what you have to say.
Okay. Well, good morning, everybody. And for those of you who don't know who I am, yes, my name is Michael Patmos. I am a board certified internal medicine physician, and I also have added qualifications in infection control and hospital epidemiology. I have devoted the last half century to taking care of sick people, and I still practice medicine a little bit every day. I'm semi-retired, but I still see patients, take care of people every day. Now, you made an interesting comment about heart disease being the number one killer. Well, that all depends on where you are. In the United States, heart disease is the number one killer, and we know what the risk factors are for heart disease, and we know how to reduce heart disease. Let me just take a minute to talk about the risk factors. The known and identified risk factors for heart disease are genetics, male gender, age, smoking, hypertension, hyperlipidemia with high LDL cholesterol, and diabetes. Those are very well defined risk factors. And we know that if you reduce those risk factors, you can reduce the development of coronary artery disease. When we say heart disease, we have to be specific. There are many kinds of heart disease. There's coronary artery disease due to hardening of the arteries or atherosclerosis. There's also valvular heart disease, rheumatic heart disease, which is due to infection. Strep throat, actually, years later leads to rheumatic heart disease. So we have to be specific about what heart disease we're talking about. In the United States, coronary artery disease, atherosclerosis, hardening of the arteries, leading to occlusion of the coronary arteries is the number one killer. And it's because we have an aging population with risk factors. Now, I can tell you, having been a doctor for 50 years almost, and the literature supports this, that the incidence of death from coronary artery disease and myocardial infarction has declined. It's dramatic. Back when 50 years ago, when I would work in the emergency room, most patients, it seemed like 50, 60% of the patients or more coming in with acute myocardial infarctions. You don't see that so much anymore. In fact, I could tell you a little anecdote of sort of I guess it's humorous in a way, in a sort of a macabre way. But I was once a chief executive officer for a hospital-employed medical group, large medical group, 135 doctors employed by a hospital. And I got called on the carpet by the hospital CEO because the budget for heart attacks, the hospital actually budgeted for how many heart attacks they would see in a year. The budget for heart attacks was not being met. Basically, people were not coming in with heart attacks as we would expect. And the CEO was angry about that. What's the problem? And I said, there's not a problem. This is a good thing. We're reducing the risk of heart attack. And what has really dramatically reduced the risk of heart attack are the statin drugs. Statins lower LDL cholesterol, and that reduces the risk, and it helps to actually, there's actually good studies that show that the degree of coronary artery disease is reduced by reduction of cholesterol through the use of statins. So over the decades, risk of acute myocardial infarction has actually gone down. Having said that, heart disease is still the number one killer in the United States because we have other risk factors, diabetes and so forth, and the population is aging. We have a gradually increasing aging population in the United States, and that leads to more heart disease. So yes, heart disease is our number one killer in the United States. Number two is cancer. But that's not true around the world. Around the rest of the world, the number one killer is infectious diseases, malaria, tuberculosis, diarrheal illnesses, various kinds of sorts of infections. So when we talk about heart disease as being the number one killer, that's sort of a disease of affluent nations where people live to get older and then succumb to diseases of age. In the rest of the world, that's not the case. Infections are still the leading death around the world. Now, you asked a question about vaccines and heart disease, and that gets at the question of myocarditis. And I just recently had the opportunity to review the literature on myocarditis and the COVID vaccine in particular. And this has really been distorted by the anti-vax people, especially Dr. Peter McCullough and his McCullough Foundation, very, very active, posting misinformation on LinkedIn. And here's what we know about the COVID vaccine, the mRNA COVID vaccine, and myocarditis. First of all, what is myocarditis? Myocarditis is an inflammatory condition of the heart. It occurs for many reasons, and it's not uncommon. Myocarditis, not having to do with the COVID vaccine, occurs frequently. About 2 to 3% of all presentations to the emergency room with chest pain. In other words, people come into the ER with chest pain every day. About 2 to 3% of patients who walk into the emergency room with chest pain will have myocarditis. I've seen and treated myocarditis dozens of times in my career, and it is almost always a immunological reaction to a viral infection. You can get myocarditis after the common cold. You can get it after influenza or associated with influenza or a whole host of other viruses. You get a virus, it triggers an inflammatory response. That inflammatory response can give you myocarditis, which is an inflammation of the heart. That can lead to rhythm disturbances, and it can even be fatal. So infection-related myocarditis is potentially very serious. Most cases of myocarditis aren't. Most cases of viral myocarditis are transient and respond to anti-inflammatories like ibuprofen. Often is effective in reducing the inflammation, and it usually goes away. But there are people who get viral myocarditis all the time. It's very common. I've seen it myself as a physician for half a century. Well, what does this have to do with the vaccine? Well, after COVID vaccination, it was a recognition. There was an article that popped up, and some of the VAERS data suggested, there might be a post-vaccine myocarditis. And indeed, there is. And it is tiny. The risk of it is tiny. You're talking about a handful of people who get this myocarditis after COVID vaccination. And it is mild. It's much milder than viral myocarditis. And it's transient. It goes away, and it's easily treated. Rarely has anyone with myocarditis suffered a severe consequence. There is no confirmed example of death from COVID vaccine-related myocarditis in the United States. Not one. McCullough and others have, and Kennedy and Bhattacharya and Prasad and Malone have exaggerated the risk of vaccine-associated myocarditis. It is not it is a problem, but it is not a huge problem. And it is far, far less than the myocarditis that you would get from the virus. If you fear myocarditis, fear COVID. The COVID virus has a much higher risk of causing viral myocarditis that is much more severe than the myocarditis associated with the vaccine, which is rare, mild, transient, and occurs mostly in younger men. I don't mean to say there haven't been some cases of people who got significant myocarditis, but there has not yet been a confirmed death in the United States. There are a couple of cases that were believed to be related to vaccines, and I think one case in a couple of cases in North Korea and a couple in Australia. But we're talking about a handful, literally a handful of people out of billions of doses of the virus. So you've had, billions of doses of the vaccine. We've administered billions of doses of this vaccine. It has saved millions of lives. And the risk of myocarditis, we now know, is tiny. It's transient, it's mild, it's easily treated. It's a tiny problem compared to what you see with the virus. So to sort of just kind of summarize that again, heart disease is the number one killer in North America, not around the world. Around the world, we're still talking about infections. Infectious diseases are the number one killer. Number two, heart disease, coronary artery disease is very modifiable by modifying your risk factors. And smoking is the biggest risk factor. Diabetes is an enormous risk factor. And hypercholesterolemia is a big risk factor. We have very good evidence that the treatments we've given over the last several decades have reduced the incidence of myocardial infarction. You don't see it as much as you used to. And in fact, cardiologists are complaining. I have some of my cardiology friends say that, they'll operate for free food. The incidence has actually gone down. So, and it is a disease of age. But we have to distinguish that coronary disease from inflammation of the heart, myocarditis. Myocarditis is a common component or consequence of viral infections. We see it all the time in the emergency room. COVID vaccine associated myocarditis is really rare, and it is mild and transient. If you fear myocarditis, fear the virus, not the vaccine. So I hope that clarifies a little bit about what you were asking. I was thinking we were going to talk about a different topic, but that one is a favorite of mine, and I had just recently looked at the literature on myocarditis. So I hope you found that interesting.
So I recently saw some studies on Twitter. I mean, you can find anything on Twitter, good information, terrible information, but there are some studies that indicate that being vaxxed against COVID can actually lower your risk of cardiac events. Also, if you're having chemo and you're vaxxed, it lowers your cancer risk.
Yes, that is true. And dementia, COVID is associated with long COVID or persisting symptoms, a persisting viral infection, I suppose, but at least a persisting hyperinflammatory state that it's now been associated with dementia later on. So yes, vaccination prevents a lot of problems related to COVID. There's just no question. The data is overwhelming. The vaccines are effective and they're safe. No vaccine is perfect. There's always, it's a matter of how big the inoculum is. Here's the analogy I like to make. Think of a vaccine like a security force. Let's say you had you're at the Alamo and you've got 100 soldiers guarding you. They can protect you. You could overwhelm them if the enemy is big enough, but they're going to get some protection. Well, a vaccine gives you some protection. It can be overwhelmed if you get a big enough inoculum. So no vaccine is 100% perfect, but the COVID vaccine clearly reduced risk of infection by about 50%, risk of death and severe disease by upwards of 90%. That's not trivial.
So you like to talk about anti-vax charlatans who say vaxes are terrible and are very willing to take your money and sell you ivermectin. but I want to mention there's a whole charlatan industrial complex. Once you start believing some bullshit, there's a billion other people who will present you with their BS. You can go from being an anti-vaxxer to being an anti-statin. There are anti-statin conspiracy theorists to believing that climate change is a plot against you, that COVID is a plot against you. There's an endless world like where if you take it as far as you can, you end up believing the earth is flat. There are
You're absolutely right, Rick. There is a charlatan industrial complex, and there's more money to be made on social media with podcasts and with your YouTube channel selling misinformation. If you have a product you can sell with it, and there's so many examples of people who do this, and if you research what they've made, they've become hideously rich. The most famous one that I can think of is Dr. Joseph Mercola, who's a practicing primary care doctor and older fellow, and he started gravitating toward this wellness stuff and selling vitamins in his practice years ago. Well, he's very active online, and his net worth documented online to be hundreds of millions of dollars. No doctor we make a good living, but no doctor with a legitimate practice is going to accumulate hundreds of millions of dollars. But these charlatans, these snake oil salesmen, have for years made a living doing this, and the internet and social media has really allowed this to expand. And now we have these same people who do this, sell misinformation, and then attach it to the sale of a product like Dr. McCullough. They're making a fortune. The McCullough Foundation is a very financially, and the wellness company, they'll sell you packages like home kits that contain ivermectin, hydroxychloroquine, antibiotics, steroids, inhalers, just in case a virus. You can buy these kits and keep them at home and treat yourself. That's bad medicine, man.
Also, but before we started the show, you mentioned frontal lobe dementia, and so it's interesting. Like when dementia starts in your frontal lobe, that disinhibits you from being a bad person. Your frontal lobe is what keeps you in line. So somebody could be a good doctor for 30 years, and then they get hit with frontal lobe dementia, which is an early dementia. It can start in your 50s, and a good doctor can become disinhibited. I've read stories and start just becoming a drug pusher or a pimp. They just go crazy. I mean, somebody with frontal lobe can go crazy. So you can ask, how can a doctor with this illustrious history become a shyster? And A, it can be the money, or B, it can be organic brain disease.
Well, that's a quick pivot to another very interesting topic, but that is true. Frontal temporal degeneration is a very specific type of chronic neurodegenerative disease. It's not Alzheimer's disease. It's not vascular dementia. It's a different thing. We don't really know what causes frontotemporal degeneration. And the interesting thing about frontal temporal degeneration is that it plays out over decades. A person can start to have signs of it when they're in their 40s or 50s and not die until they're in their 70s or 80s or 90s. So it's a very long-term thing. But here's one of the hallmark manifestations of Of course, it depends to some extent. There's three types, and it depends to some extent on where in the frontal temporal area the disease occurs. But one of the hallmark manifestations is people with frontal temporal degeneration will say outrageous things, bad things, as if it's perfectly normal. Does that sound familiar? Here's an example. There have been many cases where patients with this disease will have been reported to say things like inappropriate things in a grocery store. A wife with a husband who has this disease, they go to the checkout counter and the husband starts flirting with the cashier and suggesting that they have sexual intercourse. And the wife is like, oh my God, this is terrible. What's he saying? That's frontotemporal degeneration, blurting out, saying stupid, irrelevant, inappropriate kinds of things. Sounds familiar? Sounds like we know somebody who says this.
Well, that person
does this all the time.
Well, there's a characteristic gait associated with certain types, but the trouble with discussing gait about that person we're talking about is that person wears lifts in his shoes that throw him forward anyway. So is it the dementia, or is it just because he wants to be an inch and a half taller?
I don't know, but I think that's a whole nother topic for where we got started.
Yeah, I think we'd have to do another whole show on
Well,
dementia.
that needs a whole.
That is a big problem.
There's a bunch of around your heart. There's so much going on that when you have chest pains, you should get it checked out. But you have pec muscles. Then you got your intercostal muscles that stabilize your ribs, and then you got your heart. Like often they diagnose myocarditis in young high school athletes, and those are the guys often who are working out and their heart's going bam, ba, bam, ba, bam, ba, bam. And if you're exercising and you've made your muscles sore, you can't. It's very hard to tell the difference between muscle pain and other pain.
Rick, you should have been a doctor. You're absolutely right. When patients come in with chest pain, what the doctor has to go through is try to sort out where is this chest pain coming from. Very often it's chest wall pain, or what's also called Tetzy syndrome. You get inflammation of the ribs and where the ribs join to the breastbone and the muscles, the intercostal muscles. That can be related to weightlifting or other mechanical things. That's different than heart disease. You can have pericardial inflammation, myocardial inflammation. You can have coronary artery disease. You can have valvular heart disease. There's all sorts of things that can cause chest pain. Lung disease can cause chest pain, pulmonary embolization, infection, pleurisy, esophageal disorders, many, many different causes of chest pain. And that's what doctors do, is we sort through and figure out which it is. But myocarditis is what we originally started talking about here. And myocarditis is most of the time associated with viral infections and sometimes trivial viral infections. You can get myocarditis with rhinovirus. So myocarditis didn't just pop up out of the blue. It's not a new thing. We've always had, like I said, 2 to 3% of all chest pain presentations in the ER turn out to be myocarditis due to viral infections. Vaccine-associated myocarditis is tiny problem in the grand scheme of things. If you fear myocarditis, fear the virus, not the vaccine.
Dr. Patmos just popped in and everything. I'm surprised y'all didn't mention one of the most common things that is a cause of chest pain and all along those lines, but it's something that we all have to deal with. And I know Rick's going to really enjoy me mentioning this and everything, but it's that thing called body gas and everything like that, because that can also cause pain in the chest as well as other parts of the body as well. But I'm surprised you didn't mention that, because you can have some food that you ate or something else that could cause gas pains that can lead to chest pains.
I did kind of, when I said esophageal, I should have been more broad. Gastrointestinal issues can present as chest pain. Let me give you a few other examples. Yes, you can have spasm of the esophagus that can give you chest pain. You can have stricture of the esophagus, esophagitis, all esophageal pathology can cause chest pain. But going further down, if you have a hiatal hernia and you have your stomach up in your chest and you have a big ball of gas in your stomach, you can get chest pain from a hiatal hernia. And it's not unusual to see patients in the emergency room come in with chest pain of a gastrointestinal origin. Gallbladder disease can cause chest pain. Pancreatic disease can cause chest pain. There's so many causes of chest pain. It's one of the most common presentations to a hospital or to even in the emergency room, urgent care, even a doctor's office. And working through the whole myriad of causes of chest pain is complicated and takes a lot of training and years of experience to figure out which is which. Not all chest pain is heart disease.
So I've got a buddy who's married to a doctor who told me you want to get your pooping in order. Because one of the main causes which I don't entirely believe, of deposit of plaque onto your arteries is people straining to poop, and if you have a bunch of fat in your blood, that'll push what do you think?
I think that's a kind of a poopy connection. We know the risk of atherosclerosis may very well start with an infectious process that causes inflammation in the endothelium. Then that leads to platelet aggregation, and it leads to lipid deposits in the endothelial cells. But there is reason to believe that infection may be the ultimate trigger. So here we go again with infection. One of my professors used to say jokingly, all diseases are infectious diseases, but it was tongue in cheek. But the reality is viral infections can trigger inflammation in the endothelium, and then you can get because the endothelium is inflamed and diseased, lipid deposits form in there, and then you get platelets. So a plaque, when you have a plaque in your coronary arteries that ruptures and causes occlusion, it's a plaque that's a mixture of lipids and platelet aggregation, and it gets triggered, and then it forms a clot, and that's how you have a heart attack.
Can you reverse lipid deposits?
Alluded to it, and all along those lines, I know we're winding down, but I know that I've had people with this issue in their health and everything along those lines, but you could do a whole show on gut health as well, Dr. Patmos, because blockage is a real thing. I've had a cousin or a uncle's nephew, because he's actually on that side of the family, that's been dealing with that for months now because he had a severe blockage and all along those lines. So blockage is a real issue, and gut health is a real issue. So I know.
Yes, you made a very important point. Gastrointestinal disease is a whole nother specialty. There's a whole thing called gastroenterology. There's a whole surgical specialty called colorectal surgery. Yes, a lot of patients die because of gastrointestinal blockages and other sorts of problems like that. That's not new. We have a lot of specialties that deal just with gastrointestinal disease. But you mentioned something very important, that is gut health. So when I took a course at Harvard a couple of years ago, and the professor was talking about the 5 most important advances in recent years, and the understanding of the gut microbiome. So we've always known that we have billions of bacteria in our intestines, and what we eat and the medications we take, like antibiotics, can affect the mixture of bacteria that we have. Well, it turns out that microbiome, the bacteria in our gut are very important to our health. It's actually considered almost like another organ, and we're just beginning to understand how the gut microbiome can be related to many other diseases. This is a very new area of medicine. It's very exciting. We look forward to a lot more understanding about the gut microbiome and how to maintain a healthy gut microbiome. We got most of 90% of when you have a bowel movement, 90% of the stool is bacteria. And so the bacteria in our bowels is very important to our health. But what is the right kind of bacteria? This is all new stuff. And we have a long way to go before we really understand it. They did make the point that there are certain foods that promote a healthy microbiome. And one of them is those Korean appetizers. What do you call that? There's a Korean appetizer. If you go to Korean restaurants, kimchi actually is supposed to be, there's actually studies that show that's actually good for your gut microbiome, but there's more to come on that. This is a very early area of investigation.
So a quick question. There used to be something called the Pritikin diet, where they claimed that, if you had arteries that were 70% blocked, with clean eating, you could gradually reverse it. Is that legit or not?
I think there probably is some value to that, but the Pritikin diet, got pushed aside when the statins came along, because statins, when I was a young doctor, we used to give people Questran, is stuff that you stirred up to try to absorb the cholesterol from the diet. And if you could reduce your cholesterol by 10%, we're like, oh my God, that's amazing. Along come the statins. Overnight, you can reduce your cholesterol by 50%, 90%. It's like they just blew the Pritikin diet away. The statins are so much more effective at lowering cholesterol.
And will statins slowly revert? Oh.
Yes. There's good evidence that long-term use of statins reduces coronary artery disease. There's been plenty of studies document with coronary angiography that vessels actually increase in diameter, plaque size is reduced. Yes.
Whoa. So there's hope for me yet. So with that, we'd like to thank Dr. Michael Patmos, who's board certified in internal medicine, and our audience in the United States and around the world as we're discussing heart disease, the number 1 killer in the United States, but not around the world, but certainly high up in other places in the world. We'll see you next week on Medicine and Science on the Pod. Bye-bye. Bye-bye.